Hello, and welcome to our presentation on pregnancy considerations in treating bipolar 1 disorder, the case of May Kimura. I'm Mikael Aviso, and today, Amanda Seal, Sabrina Session, and Catherine Turner will be joining me to explore how to manage bipolar 1 disorder during pregnancy, including the risks, treatment options, and care planning for patients like May. Let's begin by introducing the case. Mei Kimura is a 29-year-old individual who was recently hospitalized for a manic episode related to the diagnosis of bipolar 1 disorder. Mei is now stable and seeking follow-up care. They and their partner are planning to start a family soon, which raises important questions about managing bipolar 1 disorder safely during pregnancy. In today's presentation, we'll focus on how pregnancy affects the treatment options for bipolar 1 disorder, covering medication risks and recommendations. Let's first talk about the risks associated with the medications used to treat bipolar 1 disorder during pregnancy. First, lithium. Lithium can increase the risk of Epstein anomaly, a congenital heart defect, especially in the first trimester, as well as neonatal toxicity and preterm birth. Valproate or Depakote carries a high risk of neural tube defects and cognitive impairments, so it's usually avoided in pregnancy. Carbamazepine or Tegretol also increases the risk of neural tube defects, craniofacial abnormalities, and developmental delays. These medications have significant teratogenic effects, particularly in pregnancy, so their use must be carefully considered. Next, we need to consider how bipolar medications interact with contraception. Oral contraceptives may be less effective when used with Tegretol, as it's an enzyme inducer that can lower the levels of the hormones in the pill, increasing the risk of unintended pregnancy. Lithium and Depakote, on the other hand, don't interact significantly with oral contraceptives, so they don't reduce their effectiveness. For IUDs, non-hormonal options like copper IUD are unaffected by these medications, while hormonal IUDs may have reduced efficacy with Tegretol due to its enzyme-inducing effect, though this interaction is less well understood. So if May becomes manic while pregnant and is not currently taking any medications, the first line of treatment would be typically a second-generation antipsychotic. Medications like quetiapine and olanzapine are considered safer for use during pregnancy, especially after the first trimester. These antipsychotics carry a lower risk of teratogenicity compared to mood stabilizers and can help control acute manic symptoms.
Now, if May is already taking lithium and becomes manic during pregnancy, the decision to continue the lithium must be carefully weighed. Lithium can be continued with regular monitoring of serum lithium levels as renal clearance increases during pregnancy. Dosing adjustments will be necessary to maintain therapeutic levels. Regular monitoring is critical as stopping lithium abruptly could lead to relapse, but continuing lithium comes with its own risks, including Epstein's anomaly. In many cases, lithium will be discontinued and replaced with an SGA or mood stabilizer. For long-term management, we would consider lamotrigine. It is FDA approved for the maintenance treatment of bipolar 1 disorder. The starting dose is typically 25 milligrams per day, which is gradually titrated up every 2 weeks to reach a therapeutic dose of 100 to 200 milligrams per day. Lamotrigine is taken orally, and the slow titration helps reduce a risk of rash, which is one of its main side effects. Before starting lamotrigine, some baseline labs are necessary. A CMP should be done to assess liver function, as the liver metabolizes the drug. Renal function tests will also be important, though lamotrigine is not heavily dependent on renal clearance. Finally, a CBC is recommended to monitor baseline blood health, which can help identify any issues that arise once treatment begins. Lamotrigine has some common side effects, including a rash, which can be mild but should be closely monitored as it may lead to more serious conditions like Stevens-Johnson syndrome. Other common side effects are dizziness, nausea, blurred vision, and somnolence. These effects are generally mild, but it is important to communicate with patients about what to expect.
Serious adverse effects of lamotrigine. Now, let's discuss the serious adverse effects of lamotrigine. The most dangerous is Stevens-Johnson syndrome, a life-threatening skin condition. Another rare but serious condition is aseptic meningitis, which may present with symptoms like headache, fever, and neck stiffness. Lastly, blood dyskersis, such as low white blood cell counts, can occur but are extremely rare. It's crucial to educate May about these potential risks and ensure they understand the importance of monitoring for these symptoms.
Lamotrigine has several important drug interactions to be aware of. Valproate can increase lamotrigine levels and heighten the risk of developing a rash, including Stevens-Johnson syndrome. Carbamazepine decreases lamotrigine levels by inducing liver enzymes, so the lamotrigine dose may need to be adjusted. Oral contraceptives containing estrogen can also decrease lamotrigine levels, so this interaction should be closely monitored and doses adjusted as needed. This may be important for May to keep in mind after birth. May would need to speak with her doctor about choosing a non-hormonal oral contraceptive. If May decides to breastfeed, she will need to speak with her pediatrician because lamotrigine does enter breast milk. And ginseng can increase lamotrigine levels in the body and should also be avoided. And folate levels can decrease while taking lamotrigine, so May would likely need to take a folate supplement during her pregnancy. There are several trusted resources available for guiding medication selection in pregnancy and during breastfeeding. LactMed is a peer-reviewed resource for understanding how medications affect breastfeeding. Mother to Baby offers evidence-based information on medication use during pregnancy. The American College of Obstetricians and Gynecologists provides guidelines on managing bipolar disorder in pregnancy. And finally, Micromedics and UpToDate are valuable resources for real-time drug safety information during pregnancy and lactation. In conclusion, treating bipolar I disorder in pregnancy involves a delicate balance of minimizing risk while maintaining effective mood stabilization. We've reviewed the risks associated with common bipolar medications, contraceptive considerations, and our recommendation of lamotrigine for long-term management in May's case. Close monitoring and regular communication are essential to ensure a safe and successful pregnancy for patients like May. Thank you for your time, and we are open to any questions. Here are the references we used to guide our discussion today, including peer-reviewed resources and clinical guidelines. Thank you for watching.